This is my oral presentation on case number 2, Mr. Evans. Mr. Evans is a 29-year-old male who presents with acute onset of severe dizziness, headache, and neck pain, which started 2 hours prior to arrival. The patient reports that his headache resolves with ibuprofen and has never been associated with an aura. He also reports that he has never experienced vertigo before. The patient has no known vascular disease and does not have a history of hypertension, diabetes, AFib, tobacco use, coagulopathy, cocaine use, or malignancy. He also reports that he saw a chiropractor for cervical adjustment about 1 hour before his symptoms started. He sees his chiropractor regularly and has never had any symptoms subsequently. On exam, the patient appears uncomfortable. His vital signs are normal except for a mildly elevated blood pressure, which is 140/90. His cranial nerve exam and gait are normal. He has no nystagmus or dysmetria. The remainder of his exam is unremarkable. As far as assessment, the current leading hypothesis is vestibular migraine. The active alternatives and the do not misses include cerebellar hemorrhage and vertebral artery dissection. However, Mr. Evans does not have classic migraneous symptoms. He does not have current episodic vertigo. He does not have current or prior history of migraines, and the other life-threatening differentials have not been ruled out with diagnostic studies. Therefore, the plan is to admit to ICU and order a head CT without contrast. The results of the CT came back negative, which rules down the likelihood of a cerebellar hemorrhage. On reevaluation, Mr. Evans complains of weakness on his left side, and a neurologic exam reveals a new flaccid paralysis on the left side. Therefore, the full admission orders include keeping the patient in ICU. The admitting diagnosis is vertebral artery dissection due to new flaccid paralysis on the left side, vertigo, headache, neck pain, and recent chiropractic manipulation. The procedures include an emergent MRA, and we are still awaiting results. The condition of the patient is stable. Activity is to ambulate with assistance due to his left-sided paralysis. Vital signs are to be checked every 2 hours. As far as allergies, there are no known allergies. Diet is nothing by mouth in case of aspiration. Medications include prophylactic aspirin and acetaminophen for pain control while awaiting results of MRA. If the results come back positive for vertebral artery dissection, we are to administer 18 milligrams per kilograms per hour of IV heparin for 5 days. For labs, if the patient is given the heparin, we are to monitor the bleeding time because this is an anticoagulant medication. And as far as special instructions, we are to alert the PA if symptoms become critical. Thank you.